Welcome, knowledge seekers and professionals, to the channel of the Swiss Journal of Radiology and Nuclear Medicine. A quick heads up, the following audio does not include any images, tables, or other additional information. If you're interested in the following paper, please visit our website listed in the caption below. Now, let's get started. Today, we're going to dive into the scientific publication with the title Comparison of CT and MR imaging of cystic renal masses by using the Bosniak classification system by Kevin Danishvar, Johannes Huber, Wolfram E. Bosbach, Nando Merteniet, and Gerd Nolge. Introduction. The accurate diagnosis of a renal mass relies on various factors, including the clinical history, the characteristics of imaging findings, the expertise of the radiologist, and the quality of the examination. Indeed, a fundamental component is a high-quality imaging examination under the meticulous oversight of the radiologist. Renal masses are predominantly identified incidentally through computed tomography, ultrasound, and magnetic resonance imaging. Fortunately, a significant proportion of these are simple renal cysts, easily diagnosed and often necessitating no treatment. However, there are instances of solid and complex cystic renal masses, many of which are clearly malignant and warrant surgical removal, while others may not require immediate intervention. Therefore, accurately characterizing these masses is imperative for appropriate case management. Simple renal cysts. Among renal masses, simple renal cysts stand out as the most prevalent type. They are prevalent in more than half the population over the age of 55. Small cysts typically present asymptomatically, while larger cysts may occasionally cause obstruction, pain, hematuria, or hypertension. Cysts are frequently multiple and can affect both kidneys. Both CT and MRI can conclusively diagnose simple renal cysts. CT criteria: 1. Well-defined borders. 2. Absence of a discernible wall. 3. Uniform attenuation approaching that of water density. 4. Lack of contrast enhancement. Are criteria: 1. A uniformly shaped, well-defined round or oval mass. 2. Hypointensity on T1 weighted images. 3. Hyperintensity similar to urine on T2 weighted images. 4. No enhancement post-gadolinium administration. Complicated renal cysts. Complications in simple renal cysts may arise from hemorrhage or infection. Bosniak introduced a classification system in 1986 for cystic masses, effectively aiding in the categorization of these problematic lesions. Widely accepted among urologists and radiologists, this system demonstrates substantial inter-observer agreement in most cases. While primarily based on computed tomographic criteria, this classification system can also serve as a valuable framework for magnetic resonance imaging evaluation. It is essential to note that MRI may unveil findings not apparent in CT scans, and a direct correlation between MRI and CT findings may not always be straightforward. Classifying small renal lesions can be particularly challenging. Utilizing thin section CT with bolus contrast enhancement and meticulous attention to detail is crucial for accurate lesion classification. MRI may exhibit fluid isointensity within the cyst, indicative of a simple cyst. Conversely, increased signal intensity on T1 weighted images may suggest a complicated cyst, posing challenges in differentiation from solid masses. Parapelvic cysts, situated within the renal hilum, exhibit imaging characteristics similar to those found within the parenchyma. These cysts often cause deformation of the collecting system and are frequently bilateral. Their attenuation is higher compared to sinus lipomatosis, Renal cell carcinoma. Renal cell carcinoma may manifest as a predominantly cystic or multiloculated cystic mass. Malignant tumor cells line the walls and septa, typically presenting with noticeable thick walls, septations, and contrast enhancement. Patients and variables. Patient selection. Between January 2010 and December 2020, 144 consecutive patients with suspected renal mass underwent total or partial nephrectomy in the Department of Urology, Heidelberg University Clinic. Among them, 123 patients had cystic renal masses. Out of them, 15 patients undergone preoperative examinations using both MRI and CT within 6 weeks, which were retrospectively analyzed by 2 radiologists using the Bosniak classification system. For each lesion, images were compared for localization of lesion, volume of the lesion, number of septa or wall, thickness of septa or wall, calcification, enhancing soft tissue components, and density of lesion based on CT. Pathologic correlation was available for all the lesions. Statistical method. Data of patients have been analyzed by Professor Dr. Annette Kopf-Schneider and Professor Dr. Renate Rausch from the Division of Biostatistics, German Cancer Research Center, using biostatistical software to determine the frequency, mean, median, mode of variance, as well as the t-test, Fisher's exact test, and chi-square to determine the possible relationship of different variants. Scanners. Although the Bosniak renal cyst classification has been developed based on CT studies, it could be applied to other imaging modalities. We have evaluated CT and MRI of our patients over 10 years. During that time period, the parameters of both modalities have been changed. The parameters at the institution in site are the following. CT scanning is usually performed using a multi-detector CT scanner using CT scanner Somatom or Brilliance ICT as a multi-stage study with thin slices. Pre-contrast scans are obtained from the kidneys through the bladder to detect urinary stones, calcifications, and cysts. Arterial phase scans of the kidneys show early enhancement of renal tumors. The nephrographic phase scans are obtained at approximately 60 seconds following onset of contrast injection, which shows the normal renal parenchyma with uniform enhancement. MRI is a substitute for CT for patients in whom the use of IV iodinated contrast agents is contraindicated or whenever the CT study is equivocal. Multiphase post-gadolinium administration acquisitions provide images very similar to multiphase post-contrast CT. Our urography provides effective evaluation of the uroepithelial tissue. The MRI examinations were performed recently by using a 1.5 T system and a torso-phased array coil. All patients underwent transverse breath hold T1 weighted MRI with a 2-dimensional gradient echo sequence and transverse breath hold T2 weighted MRI with a half Fourier single shot turbo spin echo sequence. Apparently, MRI protocols have been changed over time, however. The recent parameters for the T1 weighted gradient echo sequence were as follows: 128 to 160 or 3 to 5.30 flip angle, 70 degrees to 90 degrees matrix, 80 to 118 times 256, and section thickness 5 to 8 millimeters. The T2 weighted sequences were performed with the following parameters: 3,300 or 100 a flip angle, 130 degrees to 180 degrees a matrix, 180 to 256 times 256, and section thickness 5 to 8 millimeters. A 3-dimensional fat suppressed T1 weighted fast low angle shot pulse sequence was performed both prior to and 30, 60, 240 seconds after intravenous administration of gadolinium. This sequence was performed in the coronal and axial plane. All acquisition times were less than 30 seconds to facilitate breath holding at full expiration. Results. To compare the diagnostic efficacy of CT and MRI in assessing cystic renal masses utilizing the Bosniak classification system, we conducted a comparative analysis of imaging results from 15 patients who underwent both preoperative MRI and CT examinations, both conducted within a 6-week interval out, of a total cohort of 123 patients with cystic renal masses. Based on CT imaging, the distribution of lesions included 1 Category 1, 1 Category 2, 3 Category 2 FADs, 3 Category 3, and 7 Category 4. Concordant findings between CT and MRI were observed in 11 renal lesions, while discrepancies were noted in 4 masses. Notably, MRI revealed a greater presence of septa within the cystic lesions during T2WH sequencing compared to CT, resulting in the reclassification of cases into different subgroups than those identified by CT. Our investigation identified no significant correlation between the number of septa and the Bosniak classification. However, a correlation was established between septa and Bosniak classification groups when considering the entire patient cohort. Within this cohort, we assessed the thickness of the cystic wall using both CT and MRI. Our findings demonstrated a statistically significant correlation between the thickness of the wall and the Bosniak classification. Remarkably, in 3 lesions, MRI revealed an upgrade in wall characterization from hairline thin to minimally thickened. This led to the reclassification of 2 masses from Category 2 to 3 as indicated in Table 3. Furthermore, we investigated the correlation between Bosniak classification results obtained through CT and MRI with the histopathology of lesions. Our study revealed no statistically significant correlation between CT-based Bosniak classification results and pathology. However, a statistically significant correlation was observed between MRI-based Bosniak classification results and pathology. Discussion. The utilization of MRI for the assessment of renal masses is expanding, driven in part by the aim to minimize radiation exposure to the general population, and primarily by the wealth of additional information it provides in evaluating renal lesions. MRI serves as a problem-solving tool in cases where CT scans lack decisiveness and is employed in the initial workup of renal masses incidentally discovered during other studies. Notably, MRI proves beneficial in characterizing complex cystic renal masses, enabling the evaluation of lesion vascularity, and it has been demonstrated that the Bosniak classification is applicable to MRI. However, it is crucial to acknowledge that MRI boasts superior contrast resolution compared to CT, occasionally revealing findings, particularly on T2-weighted images, that render septa seemingly thicker, with enhanced visibility of septa and cyst wall enhancement that may elude identification on corresponding CT images. Another advantage of MRI is evident in the assessment of hemorrhagic lesions or high-signal intensity cystic lesions. While CT may not unveil the interior of the cyst in high-attenuation lesions, MRI facilitate the clear identification of wall thickness and any enhancing tissue inside the lesion. This ability allows for the potential downgrading of some hemorrhagic cystic lesions from Category 3 to 2 FIS or upgrading to Category 4. In our comparative study assessing the results of CT and MRI in evaluating cystic renal masses using the Bosniak classification system, we scrutinized 15 patients who underwent preoperative examinations with both MRI and CT. Based on CT images, we identified 1 case in Category 1, 1 in Category 2, 3 in Category 2 FIS, 3 in Category 3, and 7 in Category 4. Findings were concordant in 11 cystic renal masses, while differences were noted in 4 cases. MRI, employing the T2W haste sequence, revealed more septa within the cystic lesions than CT, resulting in the categorization of cases into different subgroups than those determined by CT. Our study revealed no statistically significant correlations between the number of septa and the Bosniak classification in this subgroup, potentially attributed to the limited population size. However, a significant correlation was established between wall thickness and the Bosniak classification. In 20% of cases, MRI led to an upgrade in wall characterization from hairline thin to minimally thickened, resulting in the reclassification of 2 masses from category 2 fit to 3. Furthermore, MRI influenced a downgrade from category 2 FIRS to 2, significantly impacting patient management. These findings align with Bosniak MA's results. The challenge in classifying cystic renal lesions with MRI, compared to CT, lies in image quality. Indeed, there is more variability in the quality of MRI across different countries and institutions, impacting lesion evaluation. Some authors suggest the use of subtraction techniques in MRI to assess enhancement. However, we posit that the mandatory sequence for assessing enhancement may not be subtraction imaging due to the limited resolution caused by breathing artifacts. Additionally, the potential of DWI MRI of the kidney as a reliable means for differentiation requires further exploration, encompassing the discrimination of normal renal parenchyma from different renal tumors, the differentiation of benign from malignant tumors, and even the histological subtyping of renal cell cancer. Furthermore, we examined the correlation between Bosniak classification results using CT and MRI in 15 cases. Our study demonstrated no statistically significant correlation between CT-based Bosniak classification results and lesion pathology. Intriguingly, a correlation was observed between MRI-based Bosniak classification results and lesion pathology, showing promise but necessitating further investigations. Conclusion: MRI demonstrates additional septa or wall thickening that may cause a lesion to be upgraded from borderline category 2 to 3 in comparisons to CT, which potentially leads to a better case management. We have come to an end. Thank you for listening in, and until very soon with more interesting publications. If you want to share your own paper in our journal, feel free to contact our team. We are looking forward to hearing from you. Don't forget to like and share if you enjoyed this content. Click the subscribe button so that you don't miss out on future publications from the Swiss Journal of Radiology and Nuclear Medicine. Until next time.